Hi everyone, and welcome back to the Graduate Dentist Podcast, your go-to guide through real-world dentistry and a community amongst graduates. My name's Erica Huynh, and welcome to our first official full video podcast. Now, if you're listening on Spotify or Apple Podcasts, you can now follow along the video on your app, or you can watch it on YouTube. And so you finally get to put a face to the names and voices as well. Now, if you've ventured anywhere into the world of Instagram dentistry, you may be familiar with the sight of blue rubber dams and frosty onlay preparations. Words like biomimetics, DME, IDS, resin care, biobase get thrown around everywhere. But what does it all mean? Now, I know I was very much in the exact same boat when I first graduated and was first exposed to this new world of dentistry that went against so many of the things that we learned in dental school. It is the one topic we get asked more than anything else. How do I start? Where do I start? What is it exactly? And so in today's episode, we are joined by none other than Dr. Bill Gergis to demystify biomimetic dentistry. Along with Dr. Maxwell and Dr. Maheer Shah, these guys form the holy trinity that is BAD, aka Biomimetic Aesthetic Dentistry. And together, they teach internationally on the fundamental principles of biomimetic dentistry. Bill runs a phenomenal Instagram account where he teaches tips and tricks on how to get yourself out of those sticky situations. I don't think I know anyone who knows how to problem solve better than Bill does. Hate your matrix system? That's okay, Bill's made his own one. Can't quite get your Toffelmeyer to fully seat in those DME cases? It's okay, Bill's made something for that as well. Can't quite get your rubber dam hole punches to be in the right spots each time? You guessed it, Bill's got something for that as well. And so we've also locked in a cheeky deal for our graduate dentist community where you get to receive a complimentary 20-pack of Gergis DME matrices on your next order. I will include all the links in our show notes. It's single use per person and only available for the first 50 uses, so make sure you go and check it out. This is a jam-packed episode. Bill is an absolute gem of a human, and I am so grateful that he let me pick his brain as much as he did. We left no rock unturned as we dived into all the misconceptions of biomimetic dentistry. We go through Bill's step-by-step of his direct restorations, his bonding protocol, how to do onlay preparations, and all these other tidbits. This honestly felt like a crash course, and I really hope you guys are able to take away key steps and tips and tricks that you can implement straight away when you go into practice. In other news, I am also very excited to announce another project that I have been working tirelessly on behind the scenes. Exactly a year ago, I decided I wanted to start the Graduate Dentist. And so the vision began. Since launching the podcast, our platform has grown immensely. We've hosted 4 in-person meetups, bringing together over 200 dentists. Our page has grown beyond my wildest imaginations, and I am so proud of what we've achieved together as a community, and I'm so grateful for each and every one of you. But let's take it to the next level. I am excited to officially announce that we have established our official Graduate Dentist Community Discord server. Unlike other dental forums that we all know all too well, where you get roasted and eaten alive for simply existing, and it is scattered full of sheepish anonymous posts from new grads who are too scared to speak up, I want to create a space, that safe space for our community that is made by us for us. I wanted to cover everything and anything you could possibly want. We have so many different channels for you to browse and flick through and explore and jump in and chime in as much as you feel comfortable with. It's a space for us to debrief our podcast episodes, to share your key takeaways, your reflections, your unanswered questions, and the things that you want to hear more about. It's a place for you to connect and chat with one another, for us to have clinical discussions free from judgment. We have specific channels dedicated to each of these disciplines, moderated by a phenomenal team of young clinicians, new grads and peers whose names many of you will be very familiar with. We'll have channels dedicated specifically for students as you navigate dental school, for new grads as you go through the trials and tribulations of being in your first year. It is a place for our community to share our successes and our challenges together, to celebrate one another's wins and to resonate with one another's challenges and struggles, our biggest mistakes, our silly mistakes, a place for us to learn from one another and laugh about it together as well. We have social channels for you to mix and mingle, to simply chat, to vent, to rant, anything you need. It is our safe space for you to be yourselves wholeheartedly. And there is so much more we're going to make of it. And so how do you join? Check out our show notes and our socials for the link to join the Discord server. When you join, you'll be asked to fill out a short application form, which I will then personally manually screen and verify. This is to ensure that we are really creating that safe space for our community, whilst allowing us that freedom to be anonymous if you want to, and for you to be vulnerable and open and transparent with your honest experiences. I'm so excited to see this platform flourish. And so if you want to be a part of it, then join the community and I will chat to you on the server. In the meantime, I hope you thoroughly enjoy this episode with Bill. Well, Bill, welcome to the Graduate Dentist Podcast. Hello, hello.
Hello, thanks for having me. Honored to be on the #1 podcast in Australia.
Oh no, I feel like with the bad cast now, I'm being challenged, hey?
No,
How
that's
the
just a
tables have
hobby.
turned.
No, it's it's good to be here. You're doing great things, right? Like it's hard being a new graduate dentist, especially these days. Like you see on DPR every week, like a dentist posting, "Is dentistry right for me?" Like I can't do anything right, that kind of thing. It's very isolating. So it's good to have something that will support those new dentists. So good job. Proud of you.
Thanks, Bill. That's what we try, and we try to be honest and to be transparent on the show, and just for people when they listen to us on their drives to work, it's like you're not alone. We all struggle. Erica also struggles a lot, and then we're very lucky to have people like yourself who kind of guide the way and lead us and help us feel a little bit less lost when we're doing things. I was gonna say, Bill, when you know how people talk about having shower thoughts, right? I've come to realize that I have like composite thoughts, and just things that I think, just things that I think about when I'm like,
Uh,
doing all the layers and all the
uh,
curing, right? And you know
yeah.
how you guys have the bad cast, right? I was just like, if you guys are the bad cast, and like I'm the graduate dentist, right? Does that make me the good cast?
Yeah, I think you're the much gooder podcast. Yeah, for sure. Yeah, it's crazy. Like you just need to find that passion and purpose with dentistry, right? So otherwise, it's a very isolating career. So like podcasts, Instagram, social media, it just gives you that connection, right? Just finding other people that are struggling just like you, so you're not alone.
Absolutely. Well, Bill, you've been in that
Yeah.
kind of field for a little while now, even before BAD came about. You yourself, you've got a prominent dental page. You help a lot of us, struggling new grads with all these tips and tricks and hacks on how to do, difficult restorations or how to get yourself out of sticky
Mhm.
situations. How did that all come about? Like, how did your page take off? What inspired you?
Yeah. What inspired me? I guess we all have that same story, right? Where like you're working in a 3 by 3 room. At the time, the practice I was working at didn't like have windows, no sunlight. So you feel like really isolated, really depressed, especially on those hard days. So Instagram was just a way of kind of like reaching out to kind of like-minded people and just sort of sharing the struggle. So you learn a lot from Instagram. I think I've learned more from Instagram than any course that I've actually been to, which sounds bad, but it just shows how like powerful it is as a tool to if you use it the right way.
I guess for our listeners that may not be aware of it, BAD stands for the
Yeah.
Biomimetic Aesthetic Dentistry, right? How did that all come about?
Yeah. Yeah. So I was in a group chat with Tim, Maheer, and Steve Schifferhouse, is a dentist in America. So like Instagram just connects the most random people together, right? It's like it's crazy how connected everyone really is. So we're just in the group chat and we're just having fun, right? During COVID, we basically couldn't work. So, we had so much free time on our hands and yeah, we're just discussing cases or just basic dental talk. And we realized there isn't really much in terms of biomedical dentistry education in Australia. And a lot of dentists were asking us, where can we go to learn the sort of dentistry that you're doing? So we decided, let's do it. um, So Steve kind of came up with the acronym first. So he said he's got his own company called BARD, which is I don't know what it stands for, to be honest. It's too long. It's like biomimetic, advanced, adhesive, something or other. And so he kind of said, he kind of said, whatever you guys come up with, just call it bad, a shortened version of bad. So yeah, we're just kind of coming up with words, and yeah, what stuck was biomimetic aesthetic dentistry. That was kind of the origin story, I guess, in a group chat back in 2020, I think it was. And yeah, from there we just posted a lot of memes, really. So
It's what we relate
I
to,
think,
hey?
we realized pretty early on what gains traction is the memes. So people don't care about your dentistry; they just care about the memes. So that just really going all in.
In for a good time.
Yeah, exactly. I can't remember who it was. Somebody asked him like, what motivates Bill? Like, I
Mm.
just don't understand. So I think it's just having a good time, having a laugh. So, if you take it too seriously, you just won't enjoy dentistry. So yeah, that's sort of how we started. And then we didn't actually, we kind of said, oh, yeah, let's run a course. And then we didn't actually really do anything until 2 years after that. So back in
Mm.
2022. And it was kind of, I feel like we've all got a bit of ADHD in us. So we need like a deadline to actually do stuff. So we spent 2 years, yeah, let's do it. But until we actually like had a date and started getting bookings, then we started, all right, we need to actually plan the lectures, the hands-on, figure out what we're going to do. So
Mhm.
yeah, the first time we actually met Tim and Maheer face to face was when we were teaching a course together in Perth.
Oh, you hadn't met
So
beforehand.
yeah, we hadn't actually met beforehand. So
Oh,
yeah,
no
that was really
way.
cool. They're exactly how you'd imagine, like online. They are like true to person, I guess.
Well, I
So
guess
yeah,
to
that was
be
really cool.
fair, I met
Yeah,
all three of you for the first time
yeah,
when I attended the bad course, like last month or the month
yeah,
before. But very much
yeah,
so that the way you guys are online is
yeah,
exactly how you are in person. You're a bit of an enigma and
yeah,
mystery though, Bill, because
yeah,
there's no aside from all the dentistry and all the memes that you post, your face
yeah,
isn't on your account, nothing is
yeah,
there. There's no real person attached to the name until you meet you in person. And I remember my first impression of you. I knew I liked you immediately when I think I asked you a question. I was like, Bill, you print all this stuff. Like, what's the best thing that you 3D printed? And he just looked at me and then like pulled down your lip to show me is it your 4.5 or your 4.4?
yeah. One of those.
And then
Yeah,
you're like,
yeah.
oh, I have a surprise Pikachu 3D printed and bonded onto my tooth.
That's so funny. Yeah, I had like a huge cancellation, like 3 hours, and I wanted to figure out the settings on the 3D printer for the new permanent resin that we were using. And I was like, oh, what better way than just print a meme and stick it on my tooth?
The greatest meme of all. No, that's awesome,
Yeah.
Bill. Um,
Yeah. I was gonna take it off straight away, and then
yeah.
my nephew saw it. He's like, Pikachu, I want one. And he wanted like five of them. And then we managed to haggle it down to one.
Yeah. Did you make one for him?
He lost his baby tooth before we could glue it on. So yeah, unfortunately he missed out.
Oh, oh, what a shame. Right?
But yeah, we can't convince his mum to give him one on his permanent tooth, unfortunately.
Oh. Well, maybe sometime in the future.
Yeah, yeah.
Yeah, so you were saying before, Bill, about like how like BAD all came about. And that, yeah, I think it's a common question about people wanting, they hear a lot about biomimetics and it's perhaps a little airy fairy hocus pocus term that gets thrown about because during dental school we don't learn anything about it, right? I knew nothing of it from dental school until I really graduated. And then you get into the well, you get sucked deep into the realm of Instagram dentistry, and then you hear people talking about it here and there, and you see all these beautiful posts of people doing, their crispy onlay preparations and whatnot. And we get so many questions day in, day out from people like, okay, well, where do I want to do this, but how do I get into it? How do I learn? It's something that's so against, I guess, dental school philosophy. And perhaps we'll like dive into it a little bit, but I wanted, I guess, your thoughts on, what do you think is the biggest myth about biomimetics or biggest perhaps misnomer, misconception about it? And if you do a little bit of a
Yeah.
myth busting session right off the bat.
Yeah, I guess it's a really deep rabbit hole, like once you get into it, right? Like it just doesn't end. Um, but the idea of the biomedics isn't something new. So, Pascal is considered like the father of biomedic dentistry. But he didn't invent the word. It's always existed beforehand, like a lot of engineering um, kind of uh, models and ideas are based on biomedics. So they look at nature and try to replicate that in their kind of designs, like airplane wing designs are based on birds and that kind of thing. So it's nothing really new, but it's based on the idea that sort of nature is better than anything we can create. So nature has figured it out perfectly. So what better kind of model or reference to use than the original? So we're trying to get back to the original design. Um, so yeah, the intact natural tooth is the reference. So just filling a hole doesn't fix the problem. You have to restore the biomechanics as well and the appearance to actually do biomedic dentistry. So I think the biggest myth with biomedics is that it's something special. So anyone that's doing good adhesive dentistry is probably biomedic without even realizing it. So that's because that's all it is when it comes down to it. It's just good adhesive protocols, using rubber dam, drilling less because you can actually bond to the tooth, and actually believing that you can bond to denting. So it's been ingrained into us in dental school. Denting bonding doesn't exist, right? Your composites will only last 5 years maximum. Whereas we know if you actually read the science, it depends what bond you use and your technique. So it's not like amalgam where you can have, the mouth flooded in saliva and it will still work. Composite is very, very technique sensitive. So it just depends on how you do it, whether it will work or not. So yeah, the biggest myth is probably just thinking that it's something special.
Yeah.
But yeah, it's just good adhesive dentistry done properly. Yeah.
I think, yeah, it seems like a big pill to
Yeah.
swallow or something that's unachievable, unattainable because perhaps we don't understand what it is. It's just this fancy word that gets thrown out. But what I like how you said is that, well, at the core, we probably all do it to an extent and just don't realize it. But let's talk about that bonding, that adhesive dentistry that you were saying that is so key and critical towards good biomimetic dentistry. How does that look? If we take it in the context of the day-to-day bread and butter fillings that we do, right? You said it starts with rubber dam. Why is that?
Yeah. So it's hard to find like studies saying rubber dam is like clinically significant. I think there was one that came out quite recently, but before then it was like really hard to say cotton rolls are worse than rubber dam, right? It's like dentists would say, oh, it works in my hands, right?
Absolutely.
um yeah, but there is one study I like to quote. I'll need to find the exact name of it, but they basically compared rubber dam versus different levels of humidity and the effect that with how well your composite kind of bonds to the tooth. And they got two samples, so one with high humidity and one with low humidity. And they stressed those samples until failure. And they found the bond strength was fairly similar between both. But what was different was the failure mode. So the samples that were in high humidity, they had failures that showed complete delamination of the hybrid layer. So you had completely exposed dentin when they stressed those samples to failure, or you had partial exposure of dentin. Whereas the ones that were in low humidity, no matter the failure, the dentin was always sealed. So that comes back down to, you can still have a bonded composite, but have post-op sensitivity. And that's because you don't have a fully sealed hybrid layer. So yeah, I mean, it can still work. It just won't work as well. So you have patient dentists complaining, oh, composites, they're always sensitive after I place them. And it all comes back to technique. So biomedical dentistry is just teaching you how to bond to dentin in the best way possible. And we can kind of go through that if you
Yeah,
like as well.
absolutely. Because I feel like
Yeah.
post-op sensitivity is something that, is if anything,
Yeah.
we were taught that is almost the norm for when you place
Yeah.
composites. You wouldn't be, and I know I'm guilty of this as well. I've definitely been through my fair share still to today where, you have patients come back and some of them, and it comes like, patient adaptability. Some people are fine, but some people will come back and they're like, this feeling has just never felt right. It's still always sensitive. Why is that the case? What are the things that where perhaps it's perhaps not just one step, right? Accumulation of multiple things that may be contributing. Can
Uh,
you dive into it, Bill?
yeah, so it kind of goes back to what are the causes of post-op sensitivity. So one is occlusion. So whenever you have a high spot with a crown that you've just bonded in, you can take a while for that tooth to settle because, the crown is high in occlusion. So some dentists jump straight to a root canal, whereas all they needed to do was adjust the bite. The other main one is like caries. Sometimes you can get that sensitivity to sweet. Cracked tooth syndrome, that's a big one.
Something for later,
But the
perhaps.
main one,
Yeah.
yeah, but the main one is exposed denting.
Okay.
So the causes of exposed denting would be like fracture, abrasion, that kind of thing. But the main one with composites is having unsealed denting underneath your composite. So it's just about getting a really well sealed hybrid layer. So when people use like things like Gloomer, it's kind of like a band-aid for a well-sealed hybrid layer. So with good adhesive protocols, you don't need these extra steps to kind of hide the fact that you aren't bonding well, if that makes sense.
So how does that look then?
How does it work clinically, I guess, is if you're bulk filling, then with bulk filling, the shrinkage stress is too high. So composites shrink. And when the shrinkage stress is too high, it'll just pull against your dentin bond and rip off the hybrid layer. So when you have a defective hybrid layer, that's when you have unsealed dentin, and that's when you have post-op sensitivity. So bulk filling is a big one. The other one, I guess, is not following the instructions, right? So I feel like we'd like to take shortcuts. So when the manufacturer tells us, cure for 20 seconds your adhesive, do we actually count to 20? Like I'm guilty of that too, right? Like 10 seconds in, like, oh yeah, that should be all right. But the most important layer to be fully cured is that adhesive layer. So you really need to make sure that's cured. Like some manufacturers, they kind of build that in. So they'll tell you cure for 20 seconds because they know you want to cure for 10.
Yeah,
So
okay.
kind
Tell
of thing.
your
But
patients
it's
to
always
brush
be
for 2
better.
minutes because they're not gonna brush for the 2
Yeah,
minutes, right?
exactly right.
Yeah.
Yeah, yeah. So we're just lazy as
Mm,
dentists. So
mhm.
manufacturers are coming out with new products every day that are making us lazier, like 3-second power cure, bulk fill with no sugar stress. But like you can't take shortcuts in dentistry. So whenever, you try to take shortcuts or you tell yourself, this will be all right, it'll be good enough. That's like the exact scenario where it's not. And it always comes back to bite you. So just following the instructions is probably the biggest takeaway from that.
If we kind of break it down, I know this is like a huge can of worms. This is probably a lecture in its own. I feel like there's so many things that I want to ask you about. And we're probably going to barely scratch the surface here, Bill. But before you talked about the whole skipping steps and shortcuts and whatnot, right? And I think one thing that really overwhelmed us during dental school were all the different generations of bonding protocols. Does it matter? Right? And every clinic will go and have
Yeah.
different bonds and different
Yeah.
systems that they use, right? Does it really matter?
Yeah. Yeah. I mean, you've got to be adaptable, right? So if your clinic only has universal bond, then it's what you've got, right? So there are ways to compensate for like the material's limitations or the product's limitations. But you have to understand the limitations in order to overcome them. So, or compensate for them. So, yeah, like you mentioned with universal adhesives, they're not the same as kind of your 2-step or 3-step kind of adhesives because they mix all the components into one bottle. So the adhesives are very thin. So you get oxygen inhibition of that hybrid layer. So it doesn't really set that well. But you can compensate for that. So if you do an extra coat of that adhesive or you do thin layer of flowable, half a mil thick, after you've cured your adhesive, right? That will increase your hybrid layer thickness so that it can actually cure before it's stressed by the composite on top, which would collapse those collagen fibers. And the other issue with the universals is kind of the water content, because it's mixed in with the adhesive. So it's really hard to separate and evaporate those solvents. So the manufacturer tells you air dry for like 10 seconds or 5 seconds, just air dry longer. So 20 seconds is going to be better. They found studies have shown that it's increased the bond strength a lot more with these thin adhesives. There's even one study where they use like a heated triplex gun, like some prototype triplex, and the bond strength almost went up to like a gold standard adhesive because they got rid of all those solvents. So it's just about understanding why there's limitations in order to overcome them. So you can still use these universal adhesives. I won't drop any names so you don't get cancelled. I've learned my lesson.
You've learned your lesson. Well, what do you do, Bill? What is your current
Yeah.
protocol that you adhere to at the moment?
Yeah.
Mm.
Yeah. So if it's a deep carious lesion, what I'll do is, depends where it's located, if it's proximal or buccal. So if you look on an X-ray, you got a proximal lesion, you got like a radiolucency, right? So it's not just an empty vacuum in the tooth. So the papilla has inflamed and overgrown into that empty space. So if you place your rubber dam and then do your caries removal, suddenly you've got this big overgrown papilla staring at you. And you just know you're going to run 30 minutes late into your lunch. So it's just understanding that. So go back a step. So before I even place my rubber dam,
Mhm.
I'll do my caries removal if it's a deep proximal. I'll make sure the periphery is really clean, and I'll do the gingivectomy at the same time.
Do you do caries dye detector?
Yes, yes. So I'll use caries dye
Mhm.
and high speed bursts. I
Mm.
don't really use slow speed bursts at all.
Oh,
So
really?
if you've ever had a if you've ever had a filling done on yourself, it's the worst feeling having a slow speed burr. It just rattles your head. Um, so yeah, after that experience, I was like, okay, I can't
So
do this
you
to
just
another
do high
patient.
speed, you make
Yeah,
sure your peripheries are
yeah,
clean, but then I think it's always scary when
typically,
you're getting close to, like, the
yeah,
pulpal area, and that's where,
exactly.
like, using a high speed can be a bit scary. Like, how far do you go? Do you go until it's, like, leathery, or do you
Mm.
measure it? How do you know how much of that more central zone you remove?
Yeah, so I'll clean the periphery really, really well, because that will kind of determine whether you need to increase your gingivectomy as well. But sometimes it just keeps going subgingival, and then I'll place my rubber dam, and then I'll kind of focus in a dry field with good visibility in that central kind of portion. Um, but I'm just following the DEJ, so keep your burr on the denting side of the DEJ, a small round diamond, if it's like a premolar or incisor. If it's a molar, use a larger round diamond. And I'm just working my way in. If you look at the peripheral seal zone concept article, you can download it for free. The authors, they use like two perioprobes to kind of measure how deep to go, but never really done that. It never works, right? Usually the cusps are missing, like you have no landmarks. So I just use the DEJ as my reference point and just make sure it's really, really clean. And yeah, you should be fine. Like you can't expose the pulp or perforate. But it comes back to looking at the pre-op X-ray as well. So before you even do start your case, look at the X-ray. So if the radiolucency hasn't overlapped the pulp, then you should be okay. Because the caries is always bigger in real life than the X-ray. But as soon as you start seeing the caries overlapping like the pulp horn, that's kind of more of a case for like vital pulp therapy, in my opinion. Whereas rather than selective caries removal. I mean, there are cases where I've kind of pushed the limit and still done selective caries removal, but as a general dentist, it's best to just kind of like draw the line there, I think. Just keep it simple. So the caries on the X-ray has overlapped the pulp, just go straight to a root canal. It's like we don't have MTA, we don't have microscopes. I was talking to an endodontist and he was saying, yeah, I wouldn't really recommend pulp therapy by a dentist because it just takes too long and you don't have a microscope. You don't know what healthy pulp looks like and what necrotic pulp looks like or diseased pulp looks like to remove it. So end of the day, it's the patient's fault, right? Like, they need to
We
take accountability
That's
at some
fair.
stage. We can't just, we can't fix everything. So
Yeah. So you were saying though that you go with
yeah,
your round burr and you're like tracing the DEJ, removing it. You're
yeah,
going back in
yeah,
multiple times with your caries indicator, and then when do you stop?
yeah,
I don't know if I
exactly.
don't know if you said it, if I missed it, but
Mm.
when do you stop? Do you stop till it's all squeaky clean? Do you leave a bit of pink? Is it until it's firm? Or
Yeah, so looking at the X-ray, you'd have a pretty good idea of how far you can go. But I'd still leave a little bit of pink if it's like really close to the pulp horn. Because you can actually bond to caries based on that peripheral seal zone concept article. I think they said you can bond to like infected dentine, like the really mushy stuff at like 15 MPa, which is kind of crazy.
yeah.
Yeah, it's something like you don't really think about.
hmm
Whereas GRC bonds to normal dentine at like 5 MPa.
Oh
So you
wow.
get a better bond. Yeah, you get a
Yeah.
better bond with composite
To
to like
mush.
mush
Yeah.
than it actually does to
Okay.
dentine, which is
Wow.
kind of crazy.
Yeah.
But in saying that, it doesn't mean you don't need to remove any caries, right? Because don't quote me on that,
We
right?
just
So
take this snippet from Bill Gergis says we can just bond to decay.
yeah, right. Because yeah, the more caries you remove, the
Yeah.
less water content.
Yeah.
And hydrolytic degradation is water degradation. So
hmm
your bond will last a lot longer the more caries you kind of remove there.
Sure. There's a lot that comes with leaving university and properly adulting that no one really prepares you for. As a new grad with an income and newfound responsibilities we don't know what to do with, managing finances can be really tough. That's where JS Medical and Dental Finance comes in. Specializing in financing options tailored to medical and dental professionals, JSMDF is a completely independent broker dedicated to finding the best bank and lender for your unique situation. Led by the incredible Jason Savage, who personally came to my rescue and worked his magic and helped me secure a loan before I even started working, JSMDF is committed to supporting you throughout your personal and professional journey in whatever way you need. Whether you're looking to buy a house, a car, a practice, or pay off that year-long CPD course you signed yourself up for, JSMDF offer comprehensive advice tailored to your short and long-term plans. Their goal is to be with you from day one and thoroughly understand your financial needs and provide solutions that best work for you. And so if you're looking for some advice or you simply want to explore your options, get in touch with Jason and his team. A big thank you to JSMDF for helping make being an adult that extra bit easier and for supporting the graduate dentist community. Do you sandblast at this point?
Um,
Do you use your
that's a good
sandblaster?
question. Yeah, sandblasting is really, really good. Mostly for removing the plaque, I feel. So I feel like the edges of your margin, like especially from the buccal and the lingual views, you don't really look at it. You're always looking from the occlusal view. And then you get secondary staining around your composites. And it's because you haven't cleaned that plaque that well. So air abrasion is really good for cleaning the plaque. And also for crack kind of removal. That's a big, big topic in itself.
Okay, yeah.
Yeah. But for caries removal, just is usually what I
Burrs
go
is
for.
fine. Sure. So we've removed all the caries, and
Yeah.
then what is next in your usual
Yes.
protocol? Oh, you were saying gingivectomy.
Yeah. So it
You
was
did the gingivectomy. You've put the rubber dam on. You've cleaned it.
first. Yeah.
Yes.
Yeah. 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 So yeah, if you didn't do the gingivectomy, then you'd probably be doing a split dam, gingivectomy, and then replacing the rubber dam. So we're trying to be efficient with our steps there. So after you've removed the caries, address any cracks that are in the tooth as well. So horizontal or oblique cracks. There's a lot of debate with regards to cracks and management. No two dentists can agree, but I think it's pretty clear cut for me. So horizontal or oblique cracks, you just remove them completely because they're not connected to the tooth underneath it, and you can safely remove them. And the cause of cracked tooth syndrome is that unsealed dentine underneath that crack. So if you can remove the dentine above the crack, you can actually have access to the dentine to seal it. So remove horizontal cracks, vertical cracks. Some dentists chase them like 10 mils down the root. almost perforate the tooth, which is kind of crazy. I get like heart palpitations just looking at some of these cases on Instagram. So I don't remove them completely, but I do chase them a little bit just to have some composite inside that crack to act like a reservoir of material that can accommodate some movement.
Are you talking about cracks that are along like the pulpal floor or marginal ridges, or whereabouts are these cracks that you're referring to?
Yeah, so vertical cracks, they usually start initially
Mm.
distally.
Mm-hmm.
So that's usually where you see them. So yeah, I'll start from like the distal, let's say, and I'll chase it inwards towards the center of the tooth. Um, but yeah, there's a lot of debate with cracks. You won't find a study that will tell you what to do because it's just impossible to design.
Everyone's got a different school of
So
thought. Mm.
yeah. So that's what's worked for me.
Mm-hmm.
But you won't find a study to back it up. So take it with a grain of salt. So after we've done our caries removal, our crack kind of management, then you kind of look at the cusps, right? So if your cusps are really, really thin, like less than 2 millimeters, as soon as you place a composite, the shrinkage stress will crack those cusps. So you need to look at whether you need to cap those weaker cusps. Some people use ribbon, like fiber, to reinforce those thin cusps. So that is one option. Um, the third option is you can go for like an indirect, like an inlay or an onlay, because there's no shrinkage stress. So you can actually reinforce even the thinnest cusp if you go indirect. So let's say we're going direct, we've capped the thin cusps. So the next step is if it's not a really deep case, I prefer to do my bonding steps now. So before I place my matrix setup, I will etch, prime, bond the tooth, cure it, place my resin coat, which is 0.5 ml of flowable, which I spread around with my perioprobe all over the dentine and the cervical enamel. Then I cure that, and then I'll place my matrix setup.
Why do you do it that way before the matrix?
Yeah, so we know denting bonds take time. So it's anytime you can introduce time to the equation, you're going to have a better bond strength. Especially in those deep cases, you really want that hybrid layer to set to maximize its bond potential. It's just like hanging a picture frame on the wall. If you read the instructions, it says place the adhesive hook, wait 30 minutes, and then stress it with the picture frame.
I've clearly never read
Whereas
the instructions. Yeah.
yeah, I've done like a split mouth design with that. So in our clinic, we've got like hanging plants on the ceiling. One side I didn't wait 30 minutes, and one side I did. And after 1 year, the side where I didn't wait um,
Oh,
has. So there you go.
wow. So that was your evidence of
Yeah,
that's how the analogy
yeah,
started for the dentine
pretty
ceiling.
much. Yeah.
Yeah, gotcha.
Yeah. So if it's a really deep case though, and I'm worried about my matrix seal, then I won't do the bonding steps. I'll do my matrix setup first, just to make sure I've got my apical seal before I do my bonding steps. But if it's just a general class 2, then I'll kind of do it that way. Yeah. So with the etching, we might go through that a bit as well. So depends on what bond you're using. So we have self-etching systems and we have total etch systems. So universals are self-etching. Um, some two-bottle systems like SC Bond are self-etching as well because they have a self-etching primer. So in those cases, you don't actually want to etch the dentine with your phosphoric acid. So you just want to do a selective etch on the enamel. But I don't selective etch the cervical enamel, just the coronal enamel. So deep in the box where you see that cervical enamel, it's really hard to just etch this tiny thin line of white. Yeah, so in those cases, I treat cervical enamel as if it's dentine and just rely on the self etch. Because they found if you etch dentine and then use a self etching primer, you've over etched and the bond strength drops by like half. So you really don't want to over etch, which is why we do our IDS without any selective etching, really, at all, if you're using a self etching adhesive. But when I'm using Optibond FL, I'll total etch. So that makes it a bit easier. You just blast everything. And then prime, and then the primer, because it's got the water and the solvents. Remember, we kind of said hydrolytic degradation is water degradation. So you want to get rid of all the water. So air dry really, really well your primer. So I extra dry, even like the non-universals, I'll air dry that primer until it's like bone dry. And then I'll place my adhesive. We sort of said about oxygen inhibition, that can inhibit like 50 microns or so of your surface layer from curing. So I try not to air dry my adhesive. Instead, I'll get a dry micro brush and just remove the excess to prevent pooling there. Unless it's like a case where it's really deep and I'm not sure if I spread the adhesive everywhere, then maybe I'll just give it like 1 second just to make sure everything's kind of sealed with the adhesive. After all that, we'll cure it, 20 seconds, and then we place our flowable, which is that half a mil. That flowable just increases the thickness of your hybrid layer, so that it really, really kind of rises. So after all that, we'll place our matrix setup.
Can we talk about your layering, perhaps, or just like how you build it?
Layering, yeah.
Mm-hmm.
Yeah. So we placed our matrix setup, placed ring, our wedge. If it's like a class 2, the first step is re-walling. So I'll build up the musical kind of wall, let's say. And I'll take my read off and my matrix band off, and then you have a lot more visibility. So you're converting it to a class 1, which I think most people do these days. It's got a lot of benefits. Again, you're stressing that pulpal denting last. So you've re-walled, so that denting where you're trying to maximize the bond strength the most because it's
So
weakest.
leaving it to set
As
long as
leave it,
possible.
yeah,
Mm-hmm.
exactly, yeah, leaving that to the last. And then you just do your horizontal layers to build up the base of that cavity. Yeah, the biggest issue when you're doing like a beautiful composite and then you have to grind it all the way down and it's just like really flat is because of that horizontal layer. So if you do your horizontal layers too high, then when you start doing your cusp by cusp, then you have no space. So it just gets wiped out. So it's just about leaving, I say maybe like 2 to 3 mils from the kind of cavo surface to give you space to do your cusp by cusp. And when you're doing cusp by cusp, you're re-exposing that horizontal layer. You're not re-exposing any dentine, so you won't get decay in the fissures, but that will give you the perfect kind of height for your build up. Yeah, so that's sort of what we do. The other thing you can try is taking a pre-op bite check and then taking a photo of that as well. And then when you finish your build up, you can kind of refer back to that photo. So you can still have occlusion on your composite, but as long as you have occlusion on the other spots as well that are the same as your pre-op photo, you should be okay once the patient kind of wears off with their anesthetic.
Yeah, sure. I feel like I spend a lot of time, adjusting my bite afterwards.
Yeah.
How do we so obviously you've given ways of avoiding that, but then when we talk about adjusting your bite or cleaning off the excess, shaping and polishing your composite at the end, what kind of burrs or tools or things do you do to do that? Because otherwise you
Yeah.
spend all this time making a beautiful composite and then you have to adjust your bite and your football burr goes in and it's like, okay, it all became smush.
Yeah.
Right?
Yeah. So
Mm-hmm.
with composite, it's more like additive than subtractive. So amalgam is like you carve it out at the end, whereas composite, you want the final shape to be as close as possible before you start kind of shaping. So you want the shaping to be as minimal as possible. Mostly I'm just using discs around the cavo surface to remove flash and just really blend in those margins. You tend to see white lines when you're polishing if you overheat the tooth. So make sure it's well cooled as well. And you want to kind of use your disc from composite towards tooth, not the other way around. They found you get better adaptation that way as well. So I'm just using discs to kind of refine things. And then if you do get a high spot, if you've kind of laid your horizontal increments properly, it should be just right kind of in the middle of that cusp on the incline. So you can just get your football burr to adjust that so it's flatter, and you're not really touching the fissure. So you still have that nice anatomy without it looking flat, I guess. For polishing, you want to use a disc again if you have used the burr, because you want to get rid of the scratches. So whenever there's scratches, if you start polishing, the scratches become more visible. So use a disc as your last step, even for anteriors. So if you're going to use a burr, go after it with a disc. For posteriors, generally I use either the Ivoclar kind of wheels, composite polishers, or the Oclu brush, which is like a diamond impregnated brush that can really get into those fissures. And yeah, that works really, really well. Generally, I'll also do a glycerine cure before I start polishing and adjusting. And that just makes the surface layer like really set, really hard so that it can polish nicely.
I feel like that was really, really comprehensive and a really great way of just like all these little nitty gritty details that go into just doing a simple filling, right, Bill? A lot of these steps, it's the accumulation of all these little steps that go into doing a well sealed um, a composite filling. A lot of these concepts then also translate to when we're doing indirect as well before. So essentially what you were describing before was immediate dentine sealing, and that's kind of the buzzword that goes into when we talk about adhesive indirects as well, right?
Mm. Yeah, I mean, immediate dentin sealing, you're doing it every time you do a direct composite, right? So it's just a fancy way of saying cure the bond. So every time you do a direct filling, you're obviously curing the bond, I hope. um, Otherwise, your filling will just fall out the next day. Um, so why do we cure the bond? Is you don't want those collagen fibers to collapse, right? You want it to be a fully formed hybrid layer before you stress it. So same with indirect restorations. How is that ceramic going to stick to the tooth if you don't have a hybrid layer that's really well formed and really stable? So it's just about curing the bond before you place your onlay. The issue with that, though, is seeding issues. So if you cure the bond and then place your onlay, it might not fit. So that's why we cure the bond and then take your impression or your scan and then fabricate it to account for that added thickness. That's essentially all it is. So just a fancy way of saying cure your bond. Yeah.
There's a lot of things that go
Yeah.
into dentistry that are just fancy terms
Yeah.
for things that aren't too good.
There's a lot of buzzwords, right?
A lot of buzzwords, and I
Yeah.
feel like a bit of a story time. I think I talked about it a little bit on the Badcast as well,
Yeah.
but just this whole concept of getting into like onlays or overlays, whatever people want to say. But it felt like this whole fancy thing that, with all these fancy terms that I didn't quite understand. I was never introduced to it during university. And I think it first came about um when what happened? When I first graduated, I think I did my very first crown prep, actually a proper crown prep after graduation. Right? We love that about
Nice.
dental school. Didn't do one during uni, did one after I graduated, and did just a traditional
Yeah.
circumferential, like, full crown prep. And I showed it to one of my senior dentists, and they're like, great job for your first crown prep. But I would have done I would have done an onlay. I'm like, oh, I would like to, but how?
How?
Right?
Yeah.
How? And I find so many of my friends asking the same question of like, oh, I would like to, but how? It just seems, it's something that we haven't learnt before, or it seems so technique sensitive. I don't know how to get into it. And then I think I attended a course earlier last year, but they were teaching, I guess, the traditional preps as well. And they taught onlay preps, but it was the traditional gold onlay preps. And I think I did a post on it, and then good old Tim and Maheer both came at me.
Oh, really?
And, yeah,
Oh, bad
and they both
mafia.
came at me, and they're I know the bad mafia came at me, and they said, "Oh, who's teaching you these old school onlay preps, right?"
Oh,
And I'm like, "Look, don't shoot me. I'm the grad. I don't know what I'm doing. I'm just learning from these people that are teaching it."
yeah.
And then they gave really good insight where they said, that, because of modern day adhesives, we're able to do dentistry. That means we're drilling a lot less, but it's actually a lot simpler. And the one thing that I think blew my mind was when they said, oh, doing an onlay or an overlay prep is actually easier than doing a traditional crown prep. I was like, what? Like, really?
So true. It's
How?
so
Right?
true.
And
Yeah.
yeah. And then I got into the world of Instagram, and my first few onlay preparations, I think I learned by trial by fire, right? None of them went well. I think everything that I could have possibly gone wrong all went wrong. I didn't. I think my very first
Mm.
one I didn't have rubber dam. My margins weren't clear. It was a subgingival um, deep margin that, in hindsight, probably wasn't suitable for an onlay, particularly my first case. And then when I went and seated, so then the crown wasn't. It was done in house and it wasn't well seated, but I still thought I'd cement it anyway and pray that it would fit. It didn't fit, and so I ended up cutting it off and doing a zirconia crown prep for that one. But
Yeah.
um, that very much started the whole journey of, okay, how do I learn to do this? And then
Yeah.
you see how people do it, and
Mm.
people like yourselves. Can we kind of, I guess, break it apart and, again, more myth busting or more dispelling all
Yeah.
those conceptions about it being something really difficult?
Yeah. Like, I think we kind of mentioned it in the course, like doing an overlay or an onlay is like doing a crown prep and then giving up halfway just when it gets hard. So like you do your occlusal reduction, you break the contacts, and then that's it. Just smooth it up a bit. Um, but yeah, it's kind of like retention and resistance form was really drilled into us in dental school. But with adhesive dentistry, it's basically become obsolete and even contraindicated with adhesive techniques, because the more complex your geometry, the more retention features you have, the more slots, the more grooves, the higher the areas of stress concentration of your ceramic. So if your ceramic is sitting on a flat surface, it's like a tile. It's really, really strong. As soon as you have like a jagged surface and you're putting a ceramic tile on it, it's just going to snap. So your ceramic is actually stronger when you don't have these retention features, which were really designed for gold, not for ceramic. But also your tooth is stronger because you're drilling less. The more tooth you keep, the stronger your tooth is. It's just basics, right? You don't need the study to tell you that. I think Graham Milicic, he does a really nice lecture where he talks about this, and he says when you do a crown prep on a tooth, 50% of the strength of the tooth goes up with suction, which is kind of wild. So yeah, it's a very different approach. Adding retention features also increases the C factor. So your bonding isn't as good as well. So your bonding's not as good, your ceramic's weaker, the tooth's weaker. So you can't have it both ways. You can't have retention and adhesion. But we still don't want to let go of that retention as dentists, because that's what we were taught at uni. We want something to fall back on as a plan B in case this biomimetic jumbo doesn't work, right? In case it's all a scam we see on Instagram. We want something to to fall back on. But you have to go all in. You can't sort of
Yeah.
half do it. Yeah.
So if you were to, we did before about like your direct
Mm.
protocol,
Mm.
what would your like indirect
Indirect
protocol
protocol.
be in this case?
Yeah. You got to look at the tooth first and say, am I going to go full coverage or am I going to go
Mm.
partial coverage? When you're first starting off, I'd recommend going full coverage because it's just a safer option, right? You can't see all the cracks sometimes if you leave cusps. And it's easier to get your caries kind of removal endpoints. And it's just faster, right? Like if you're deciding whether I should keep this cusp or not, you spend like 5 minutes agonizing in your head. Whereas if you commit from the start, look, this is going full coverage, you don't have to feel guilty. Just do it from the start. So start with, if you're first starting off with onlays, go full coverage. It's already way more conservative than a full crown prep. So don't feel guilty about a bit of cuspal enamel. They call it cusp protection for a reason, right? You're making the tooth stronger when you reduce the cusps. So go full coverage. 1.5 mils is all you really need. But you tend to under reduce. So aim for 2 and you'll probably get your 1.5.
Mhm.
So
Do you do depth reducing? Because
yeah.
this has been an issue with me since graduation.
Yeah.
So I always under reduce. Even when I think I've reduced enough, I've still under reduced.
It gets the best of us, yeah. But you gotta understand the better you bond the ceramic, the stronger the ceramic will be. Especially if the surface is really smooth and flat, like we talked about. So there's been cases where I've under reduced so badly that you can see through the onlay, and I've still bonded them in. And they still work because it gets its strength from the bond. So Maheer's done like these studies on ultra thin occlusal veneers, 0.5 mil thick, made of Emax, and they've done amazingly well. And it's because they're bonded in rather than cemented. If you just use GIC, yeah, it's not going to work, right? So you have to bond these in. So I wouldn't get too caught up on minimum thickness as long as you're using Emax, because that's a really safe kind of material to go for. So yeah, get your occlusal reduction.
Do you still aim roughly?
Yeah, like I try to aim.
Sorry, just for thickness of Emax?
Yeah.
Do you still aim for 1 millimeter or 1.5?
Yeah, like 1 millimeter is the kind of the minimum, they say. So I think they started saying it was 2 mils, and then they said 1.5, and then they changed the guidelines to 1 mil because they found the Emax is better than what they originally thought, especially when you bond it in. So there was, back in the day, they had the flexural strength of Emax. I think they said it was like 400 or 300 MPa. And then like all these new materials came out on the market saying we're better than Emax. We're like 500 MPa. And then Ivo Clark came out and said, actually, ours is 500 MPa too. You just got to bond it in, right? So, Emax is, underrated. Even for lower second molars, I have no issues using Emax. It's really hard to do a crown prep on a lower second molar. Have you ever done that before? The amount of height,
but also
amount of height you get for retention.
You reduce and then
yeah.
What do you do, Bill? How do you I always find that I reduce it and then you take your scan, it's like, oh, it's all disappeared. But then I'm like, it looks like it's equigingival there and it's flat.
Yeah, just imagine that and then doing a crown prep and relying on those axial walls to hold it in. It's like, it's just setting yourself up for disaster. So onlays work really, really well for lower second molars because of that, because you don't have the height for that feral kind of effect. But yeah, you always got to adjust the opposing plunger with those lower second molars, I find. Yeah, just get a burr, chop off like a good mil or two off that power tool. But yeah, you start with your occlusal reduction. Actually, we should quiz you because you've done the bad indirect. You should remember the secrets.
Oh dear, I'm on fire. Oh, do I have occlusal reduction?
Yeah.
And then you do your interproximals.
Yeah, and then.
Oh wait, I was gonna say, wait, when we talk about the occlusal reduction, are we doing flat? But then talking about the bevel?
Yeah, so with your occlusal reduction, some people use depth cutting burrs, but what I do is I just sink the burr into the tooth, and you can see the tip is fully submerged into the occlusal fissure. And then you just go straight across the tooth mesial-distally, and then you should see an even kind of reduction across. And then once you've done one side, do the other, and you end up with like a V-shape looking prep. So that's after your occlusal reduction, and then you need to do your bevel on the outside, so the buccal and the lingual, to get that kind of dome shape effect. So yeah, we've done our occlusal reduction, we've done our bevel. So you don't always have to do a bevel. It depends how high up in the tooth you are. So the maximum convexity of the tooth, if you're above it, then you want a bevel. If you're below, you want it to be a butt joint. And the reason for that is if you're below that maximum convexity, you're losing surface area of enamel when you bevel. And the tooth gets narrower. So it's really just above that maximum convexity where you want to bevel for increased surface area of enamel and better orientation of the enamel prisms as well. Cool. So
One thing that I found with the one thing I found with the bevels was that personal mistakes early onwards is that even though you're beveling it, it needs to be like a really clear delineation, not like
infinity
bevel that we do on like our anterior, that you do on like anteriors to hide it, right? Like it's there, but it still needs to be crisp so that you can pick it up
especially
on
if
your
you're
scan,
especially if you're sending it out to a technician, they have no idea. Especially with onlays, like they used to full crowns. They don't get a lot of onlays, I feel. So you're just leaving it up to chance, and then you get like these kind of almost like a mushroom looking onlay, right? Where they've kind of guessed where the margin is and they've overdone it. And then you got to shave back that onlay to make it flush with the tooth. So yeah,
I had one the other day.
So yeah, you've done your occlusal reduction, you've done your bevel, you've broken your contacts, and then it's just about smoothing the geometry. But I don't spend too long smoothing the whole prep. Use a football burr for that step because I'm going to use my composite to smooth the prep. So I'll do my bonding steps, my immediate dentine sealing, and I'll place 0.5 ml of flowable, and I'll drag that over the dentine and the cervical enamel. So Pascal, he calls it IDS, immediate dentine sealing, but I recommend not just covering the dentine, but also the cervical enamel because it's very brittle. It breaks very easily. Just treat it as if it's dentine. And that should smooth out your geometry without having really good hand skills. So it's kind of a cheat code, just using flowable to smooth out your prep. Yeah. Really, really easy.
That was a huge game changer. Yeah, a huge game changer. When I learned from you guys how to do that, and particularly extending it into that box area, and then afterwards going in with like a soft flex just to smooth everything. I remember looking at it when we did these on the models during the course. I was like, whoa, that's cool.
I feel like it was too easy. Like you guys just like smashed your first like onlay prep using that technique, and then we didn't know what else to teach you. You already mastered it. It's just repetition, and like we need to come up with new scenarios now.
Like trickier ones.
Yeah.
But I think it was very helpful. And I think the way that you guys do it is very much distilling it, and that it's not
It shouldn't be hard.
overly difficult.
It shouldn't be
It
hard.
is very much
Yeah. Like if it's hard, then you won't do it. So you got to make it easy.
And so at that point, that's pretty much most of the prep.
Yeah, you just, like you said, you get a disc just to sharpen the edges. But you don't really want to use a burr after you've done your bonding steps because you don't want to re-expose dentine. You don't want to scratch up the surface. So there's some people that do their kind of IDS/composite build up and then they prep the tooth. But we recommend the other way around. So prep and then bond. Otherwise, you end up with like a core build up, which is more, like we said, the resistance retention form ideas from the past. So we're moving away from that. At least we're trying to.
Yeah. Do you guys do that locating? What do people call it? Like divot in the middle or not? Or is that adding more geometry that goes against?
I mean, it's not super like complex. It's not like a slot, so it's not really going to be damage things too much if you just use a round kind of burr. But I don't want to drill extra tooth away for the sake of that divot. So if it's a really deep case, let's say endo treated, then you're doing quite a large kind of composite build-up. So you have space to place that divot. So I think they call it like an endo crown as well. So you don't have to go all the way into pulp chamber to call it an endo crown. You can just do that divot and they call it an endo crown. But it's only really useful when you have a really flat prep. So let's say the tooth is like decoronated, there's like no geometry at all, and your onlay might start sliding around because of that. So in those cases, you could either do that locating divot, or you can do a small little build-up, non-retentive, just make like a dome kind of shape, just to add a bit more of a location feature to your onlay, and increase the surface area that ceramic is going to bond to. But personally, I rarely do that locating divot. Yeah, I can't remember the last time I did it. But it's not going to hurt if you do it.
Yeah, sure. And so then after this, it was very much those same. What I thought was interesting because those same principles that we talked about earlier before, like apply here, right? You cure your bond, you cure your flowable layer, you glycerin cure it so that when you do your temporary, you don't bond your temporary, which is another mistake that I've done.
We've all done it, right?
Mhm.
Temporization is probably the hardest thing, or the biggest barrier for people to start doing these non-retentive designs, because they just fall off or they get stuck. It's hard to get them in between. We can talk a bit about that. It's just that oxygen inhibited layer. So you really want to make sure that's not going to bond to your temporary. So the way to get rid of the oxygen inhibited layer is scrub it with alcohol, glycerin cure, get rid of it. Pumice can help get rid of it as well. But it's best to do like all three. So like over engineer it because you really don't want it to stick. Yeah. And then before you place your temp, saliva is the best kind of separating agent. So nothing will stick to a wet surface. And saliva's like got that right viscosity to cover the entire surface fully. So yeah, that's a really good trick.
The secret ingredient.
Yes.
The one time where we want moisture contamination to the max,
So
right?
good.
Yeah.
So if you're gonna make your temp, have saliva over the tooth after you've seated before you've seated your index and taken out your temp, but even after. So when you're ready to temporarily cement that temporary, coat the tooth with saliva again and then bond it in. Yeah. That's because sometimes you might use flowable to kind of bond it in, or some people, they use flowable to lock it into the undercuts. So if there's saliva there, it won't stick. Just overdo it. Yeah.
Sure. Yeah, no, I definitely have had that issue with all my temps coming off of my onlay preparations. And there was this ongoing joke with one of the other dentists that I worked with because he would always work the following days that I wasn't at the practice. So he would see all my temps come off. And he said, Erica, I'm going to give you like a loyalty card for every 10 temporaries that come off. The 10th one, I'm going to cement with Panavia.
Oh my goodness. Have you been doing those flowable locks that we kind of talked about?
I do the flowable interproximals, but I also do the like spot etch
on the buckle
and then flowable on the buckle.
Yes. Yeah, that works so well. Yeah. But also the template. Have you seen that blue stuff? It's kind of like Telio.
Oh, yeah. Like the Clip F stuff?
Yeah, I'll show you. Yeah, maybe I'll send it to you again. But it's like this blue kind of flexible temporary material they can use. And you get it from like Independent Dental. It's like $50 for a pack of 3. Coat the tooth in saliva and just thumb it in. And it works so well.
Oh,
yeah,
yes.
instant temp.
So do you have to cure it or anything?
Yeah, just cure it a little bit, and then you can spot etch the buckle.
Is that?
Add a bit of flowable, get a bit more retention. But it's blue, so it's really obvious, and the patient will come back to replace it. It works really well, and it just peels off because it's a flexible temp.
Is it the same as like Telio and Clip F?
Yeah, very similar, but it's just a blue color. And it's probably probably half the price.
Sounds good.
Yeah. What else do we want to talk about? I feel like we've covered a lot.
I think that covers it.
Yeah.
I know. I was just like, oh man, we're getting like a mini residency here, Bill. A crash course, right?
Yeah.
Like a
but there's a lot of there's a lot of buzzwords though, like what was the one? IPDS, so immediate pre-endodontic dentine sealing. Have you heard of that one?
No, I have never heard of that. What is that?
So that's where Maheer kind of came along and said, when you're doing root canal on a tooth, you're going to use hypochlorite, which degrades the collagen fibers, and that drops your bond strength. So before you irrigate with hypochlorite, you want to do your IDS. You want to rebuild the proximal walls. You want to do your DME. You want to kind of restore the tooth before you actually do the endo. And that way you don't need to replace it after the endo. You can use that same DME composite for your onlay.
Okay,
Yeah,
sure. So do the restoration first, then do it well before you go in and do
yes.
the root canal?
Yeah, so but basically you're just removing all the restorations, all the cracks, all the caries, so you're not being selective because you're going to do root canal. Remove the coronal pulp if it's exposed and bleeding, but if it's not, don't touch it. And then you want to matrix and re-wall, and then you want to start irrigating, instrumentation, medication. I don't use GIC to temporize or cotton pellets. I just use Teflon. And then that last millimeter, I'll etch the tooth and I'll place flowable composite. And that's my temporary.
And then you just drill through your flow.
Yeah, because you're not bonding that flowable, it's still going to bond because of the etching, but it's not going to bond that strongly. So it's fairly easy to remove. And then if you got Teflon inside, it just comes out in one piece. It's inorganic compared to cotton. So they found there's less bacterial growth. It's just really hard to get rid of cotton from these root canal treated teeth sometimes. Yeah.
I just remember one of my like endodontic tutors back in uni used to always say like, oh, cotton pellet, putting a cotton pellet is like putting a wet, dirty dish towel.
Yeah.
So I've always stayed away from cotton pellets, but I actually use Cavit.
Yeah.
But thoughts on that?
Yeah, I mean that's one option. My tutor at uni kind of taught us that way. So you just fill up the whole thing with Cavit, and then you use your ultrasonic to kind of remove it. But it does take a while for that Cavit to come out, and it's still like little surface contamination that you can't quite get rid of unless you sandblast. Whereas Teflon just comes out in one piece very, very quickly. And if you use like a blue Teflon, like different color, it kind of shows through the occlusal flowable, so you know that tooth is in the middle of root canal treatment. Yeah, or if it's a temporary. Yeah.
Interesting. That's an interesting tip. I might try that.
Yeah.
Because it does make sense. Like you end up sitting there cleaning out the Cavit for ages, and I understand like all the little particles are probably not great for bonding off.
Yeah, even like temporizing a tooth. So there's been cases where I've dealt with a really deep carious lesion on a tooth, and I'm worried that it will need root canal. So like on the pre-op x-ray, the caries overlaps the pulp horn. It's like the case where I said you should do root canal, but I haven't. So in those cases, what I might do is re-wall the tooth, do my IDS. So I've sealed all the dentine, and then I'll just pack Teflon in there. And then I'll put 1 mil flowable on top. And that way the pulpal hybrid layer isn't being stressed by any composite. It's just Teflon on top of it. And then you can monitor that tooth for like let it get settled, right? Let it get mature. And then a week later, you can come back. If it's settled, just take out the Teflon and then relayer your composite. So yeah, if it doesn't settle, then you got easy access to do your root canal. So
true, you're not drilling through all of it.
Yeah. Little tip there for you.
That's awesome. Something else like that. Yeah, that blew my mind. But something I really wanted to talk about, Bill, is because I feel like today's been such a jam-packed conversation of so many concepts, but also, like really, really dense, like intense crash course for everyone. But it's questions that I'm sure you get bombarded with day in, day out. I hear a lot of it from listeners who feel overwhelmed by the concept, who want to get into it but don't really know where to start, or they get overwhelmed by all these words. And I really hope that this episode kind of helps dispel that, or dispel those myths, and make it feel like, you know what, it is digestible. It's not some hocus pocus stuff that, is undoable, but is unachievable by a general dentist. But I also feel like it's important to address the fact that I think there is also the school of thought where biomimetics does get a bad rap, perhaps from more traditional dentists where they see it as, you know, you're taking it to the extreme, right? And I think something that you guys talked about in the course that I thought was really important was that, we're trying to be minimally invasive, but we're slowing down that restorative staircase of the tooth. And that by doing these more conservative approaches, it means that if it were to fail, it fails more favorably.
Yeah.
And so that down the track, for whatever reason, if you do need to replace it, you still have tooth structure to work on. And that you have another chance at the tooth before you need to do like a full coverage crown. I think
Yeah.
something that was really important that I really liked and took away from the course was that it's not dissing on the traditional approaches. It's not dissing on retentive preps. It's just, can we do this now to prolong the restorative lifespan of this tooth? And that, look, at all worst case scenario, if all else fails, you can still fall back on our tried and tested.
Yeah. It should never be like
methods.
crown A as your like crown prep. It should always be your plan B. So you can always start with an onlay and then do a crown. Like there's nothing kind of stopping you really. But the more compromised the tooth, the more you need to rely on adhesive retention rather than mechanical retention. Because mechanical retention, it stresses the tooth to hold on. And if the tooth is already drilled down to like a little nub, it's just going to snap, right? So you want to stress the bond rather than the tooth. So it's just cool things like that you can do with biomimetic dentistry because you can trust that bond. Because you understand that you can bond to dentine at like 60 to 70 MPa. And you know that enamel and dentine are bonded together at 51 MPa. So you can bond stronger than the bond of enamel to dentine. So there's no reason why that can't work if you follow the correct protocols. So rubber dam is step one. If you can't rubber dam, then you can't really do this kind of dentistry.
I think we're probably going to wrap up that podcast because I think there's such a interesting jam-packed episode. But one question I always leave with all my guests is that obviously we have all these conversations. We have all our nerdy conversations day in, day out, right? We get really deep into our dental talk, but every so often, we have a conversation that really gets you thinking or it sticks with you. We talked before at the beginning of the episode about shower thoughts or composite thoughts, right? And I want to ask you, like, have there been any conversations recently that have kind of like had you thinking, perhaps related to the type of dentistry that you do or you try to advocate for, that you think would be important and good to share with our graduate dentist audience?
Yeah, I guess a lot of like new grads, they compare themselves with other new grads and they see them doing these complex cases or even just a general kind of composite filling. Like they'll do it in like 30 minutes. Whereas why am I taking, 1 hour, sometimes 2 hours? But we all start there. So you got to start slow, but do your best. Because it's better to do the filling once and slow than do it twice and fast. So speed just comes with time. So don't compare yourself to other people. Just compare yourself to yourself. I guess that's what they say. So you can track your own progress. That's how you improve. Photography has been really key for me. If you scroll far enough on my Instagram feed, you'll see some really dodgy fillings. So I don't recommend you go that far. But yeah, it's important to realize like we all started on the same kind of place. It's just some people take a bit longer to get to speed. And there's nothing wrong with that.
Yeah, I consider myself a slow learner. Like I'm
No, selling yourself short.
I will be the first. No. But I would say so. I'm like I probably err on the side of caution, and I'm not the fastest at learning things. I take my time, but I think a big part of it is like you trust the process, right? Everyone learns at a different pace, but also everyone has interests in different things as well. And I think that's kind of what I've come to terms with, where it's like you compare yourselves to other people, but then you kind of ask, I'm like, am I as into this as other people are? Because you progress at the rate that you put that effort into that particular thing, right? And so if you're going super hardcore into it, you're not sleeping, you're spending all the time, then of course you're going to be progressing rapidly, right? But everyone does learn at their own pace, right? So I compare myself where I am now to where I was a year ago, and yeah, it's nice to see that progression. And even the other day, we were talking today about my journey in doing these kinds of preparations, doing overlay preparations. I told you about how my first few that I did, everything that could possibly go wrong went wrong. And then the other day I did two side by side. I did a 4-6, 4-7. It was like some of the nicest preps that I'd ever done. And I think the biggest like confidence boost I got was when my DA looked at it and she's like, "Oh, Erica," she's like, "that's photo worthy." She's like, "That looks so good."
It's so funny. It's like whenever the nurse sees you take up the camera and take a photo, it's like, "Oh, this is one of your good cases, right? That you're proud of." It's like, yeah, it is.
Yeah. So the fact that she said to me, she's like, "You better be grabbing your camera out," right?
Wow.
But that was just really
That's
nice
so
to
good.
think that. Yeah. But it was nice to see that, like, hey, you do improve. If you keep working at it,
100%.
yes, it'll be hard. You'll go through the ups and downs. We all learn by mistakes. We're still learning. But I always say on the podcast, we learn most when things don't go right, and then you learn to troubleshoot. And the next time you do it, that accumulation of those little things means you get a good outcome.
Yeah.
So no, I think that's an important message to share.
And dentistry is so like varied and so wide. Like you might not be good at composites, but you might be placing all on fours every day. Like it's like it might not be your strength, but you might have other strengths. So just focus on your strengths. Yeah. If you have other interests, then whatever you're interested in, like you said, you're going to get better at. You almost have to have like that Goggins mentality, right? Where you're like obsessive about something.
Obsessive.
Yeah.
We're all a bit obsessive about something, right?
Yeah. That's your strength, right? So whatever you're obsessive about, that's what you're good at. Yeah, it's been great chatting with you. How long has it been? Time's flown, right?
About hour and a half.
Yeah. Wow.
I'm actually going to stop.
Yeah.
I don't know if we ended it properly. Thank you for joining the Graduate Dentist podcast, Bill.
Thank you. Thank you for having me.
And thank you guys so much for tuning in to another episode of the Graduate Dentist podcast. I really hope you've taken something valuable away from this episode and that you feel heard, you feel seen, inspired, and optimistic about our journey as graduate dentists. As I always say, we're in it together, so let's spread the word, let's share the love, send this to your friends, your colleagues, and those who are on a similar path who you feel may benefit from being part of the community. I'd love to hear your thoughts, so send me a message, and we'll see you again in 2 weeks' time for another episode.